Good afternoon, everyone. I was appointed by the Tayside Health Board as a 17-year-old on the 1st of January 1980. And my first duty was to have 2 days holiday. Because of the drink, you had an extra day. It's been, that's remained with me for the last 34 years, and why I can still remain in front of you and feel this is such a wonderful country to be in, and we've so much to be proud of in healthcare and in public life. And in anything I'm about to say to you, two things. Remember that. We've got so much to be proud of. There's still much to do. But also that you have, in listening to me, to remember I come with great humility. I would like you to know that there is much I'm learning, but if I sat with any of you for more than 15 minutes, you'd be able to teach me what I have yet to learn. Is that clear? I've had experience of working in healthcare. I've been in psychiatry, I've been in acute services, I've worked in the department, I've been in community services and so on. But this is a whole new world for me. So 50 years ago, a child died every 5 hours from diphtheria. My father was given false teeth for his 21st birthday. Dental clearances. I'm not going to ask you if you remember, but you remember the times. And we were dealing with the consequences of disease, and people were dying from disease. 50 years on, we're dealing with the consequences of living with disease. There's very little original, I think, of what we have to learn about where the problems might be. We had Wanless 12 years ago, do you remember? And what he had to say. And then we've had Michael Marmot in more recent years. And then in February of this year, we had the Global Burden of Disease, published by The Lancet, funded by Gates, looking at the leading causes of death and disability, and how those have changed or not over the last 20 years. So we know that the biggest killers remain, or the causes of early death remain tobacco, hypertension, interestingly, blood pressure, not very complicated. Half of all strokes would be avoided by earlier attention to blood pressure. The conditions associated with eating too much, not moving enough and drinking too much. I don't think there's anything new in that. And then in recent times, literally very recent times, we've begun to talk about this in the context of hospitals and differences in survival rates in hospitals, but very marginal to what really matters. What we haven't been talking about at all is what causes you misery when you are alive. Disability, the doctors or the academics would talk about disability or long-term conditions. But you or I might talk about depression and pain. And Michael Marmot would say, well, that's very interesting. Well, not really. It tells you what you die from and what causes you misery, but it doesn't tell you much about why and what you can do about it. So I have this vision of Marmot meets the global burden of disease. If you think of Madison Square Gardens, and Michael's in one corner, and the Lancet's in the other, and ding the bell, and say, what does it tell us about what we should be doing that's different? So I said there was much to be proud of. From a public health perspective, we've had big measures like smoking in public places in recent years, seatbelt legislation. We've had big changes in the care that people take when they're out cycling. We've had huge improvements in some areas, like cardiovascular outcomes, some cancers, stroke. But the gaps between those that have good health and live longest with good health and those that don't are as wide as they ever were. I was in Wakefield this morning. This is very common, 12 to 13 year life difference between one part of the town and the other. Or in Lincolnshire, they call it the Granddad Gap. The evidence says that young people listen more to their grandparents than they do to their parents. I have a 13-year-old who says, have you ever had that experience? All I said was good morning. Yeah. In Lincolnshire, I say, that's the Granddad Gap. They're not getting a granddad. So it's really, I think, such a fundamental question for us about why might this be when we have had 6 decades of universal access, the envy of the world. We've had huge investment in the NHS in the last 10 years. And yet the gaps are as wide as they ever were. And getting wider. So I said you knew more than I would ever learn. But you know why that might be. I was asking in Wakefield this morning, and I was in Warwick earlier this week. I said, do you remember Little and Large? Do you remember them? The comedians. Are they still alive? Are they? Little's alive, is he? Does he live in Blackpool? If he lived in Blackpool, probably he isn't. When we published Longer Lives, there's nothing new about this. There's nothing new about this. This is the thing. The further north you go, the wider the gaps. And the Times published, the headline was, "Visit Manchester and Die." Why might this be? The little bit is the constant restructuring that we do in public life. We keep changing things. And it's not that people don't continue to prosecute a career and do the best that they can. It's just that we keep disturbing relationships. And how things get done is always through people. So it's relationships that matter. And we keep doing this. And it does cause a delay. It does slow down improvement. But it's not the biggest. The biggest reason by a country mile is that we think of health and the NHS as if they're the same things. We conflate good health with the absence of disease. And we think that health care is how we're going to get the improvements in reducing these gaps. But what I'm about to say is that whilst it matters, and it does, it remains marginal to length of life and life without disability, life without misery. Hence the importance that we're going to be placing on local government with their new legal duty to improve health, to improve the public's health. They have a legal duty not to provide a public health service per se, but to improve the public's health. There's a crucial apostrophe S there. Because the things that matter the most, they're not exclusively but they matter the most is, do you have a job? And the further north you go, the higher the rates of unemployment. Do you have somewhere decent to live? Where you're not afraid to go out the front door and you can afford to turn on the heating. And the importance of not being isolated. This was the conversation up in Wakefield this morning. Organisations, mental health organisations, organisations that focus on looking after the elderly, and the importance of community and human contact. The importance of having enough money to live on, somewhere to live, something meaningful to do. The older you get, the gap between what the professionals, and there are always exceptions, but the professionals think that what matters to the elderly and what the elderly themselves say matters, quite different. It's less than a 50% correlation. I met a whole range of voluntary organisations last week who focus on the elderly, and the elderly are interested in companionship. They continue to want to have objectives in life and to engage. They've got assets, things to bring. The statutory services think of it in terms of the presence or absence of disease. Michael Marmot, says, well, if you do nothing else, focus on the first 2 years of life. I only make these observations because this isn't about health care. It's not about when it's gone wrong, almost a sign and symptom of failure. Is the need to... We've talked for years with a pride that we see 1 million people every 36 hours in the health service. Well, a marker of success will be having that number because we're caring for people at home for longer and reducing these gaps. So 3 things to convey. Public Health England has been given this amazing brief, which is to protect and improve the nation's health and to address inequalities. Clinical commissioning groups have been given the responsibility to address inequalities, a legal duty to address inequalities. This has never been placed on a health body before. And together they come together in the Health and Wellbeing Board. It's very early days. But think 5 and 10 and 20 years down the track. A legal duty on local government to improve health and a legal duty on the commissioners to address inequalities. And what we'll be doing is helping and supporting them from the evidence, locally determining what those priorities are, showing who's doing better, putting them in touch, publishing everything so that everybody can see how each other is doing and learning from each other. The pursuit and spread of knowledge. The second is influencing national policy. And I'm looking for help. There are people in this room who know how to do this. To speak with a single voice, apolitically, to all of the political parties, that in 2015, what are they going to be saying about health? So when they're in the Rose Garden, do you remember? And here are our objectives. What are they going to be saying about tobacco, alcohol, and sugar? And finally, whatever we do nationally, I've come to understand over a number of different adventures that the further you are from having to actually do something, the more confident you are that it's possible. It's a correlation between distance and certainty. And the closer you get to having to do it, the more colourful it becomes. And it's all about people. It's all about relationships. It's never quite as straightforward as you think it might be from a distance. So we're going to be focusing almost exclusively on what we can offer at a local level to help people to address these issues, which are almost all expressed at a local level. I said we should approach this with pride because there's a lot to be proud of. And I think it's perfectly possible to feel good about what you do, whether you're in healthcare or in local government or in you're in academia or you're in a voluntary setting, whatever your contribution is, to feel that we are making a difference, but at the same time, to also be able to talk about what more we've got to do. And we need to move on from thinking it's just wrong. It's not, we can't continue to stand in the same place believing that we can address the health gaps in this nation by continuing to do what we've always done, which to have 90% of the activity happening outside of hospitals, with 80% of the spend going on what happens in hospitals. And we need to get much, much earlier into working with people before things get more difficult, rather than after.